Hello, guys. I am recording a series of 3 videos for our nutrition content due to the fact that we have holidays on 2 Mondays in a row. So this is a lecture series for my class. It's first semester nursing. If you aren't in my class and you want to learn more about nutrition, obesity, and hydration, please feel free to watch these videos, but they are intended for my students, and I'm actually just at home recording on Zoom and wanting to make this good presentation for them because I want them to get the content, but this isn't my normal YouTube channel content. Okay, so as part of the nutrition hydration series, we're going to do our exemplar of obesity. So if you guys read this in your book, all of this is in your book, but I'm going to go over it with you as well. So we'll start off with an overview. Obesity continues to be a problem in the United States, with 42.4% of adults experiencing obesity. And then I put down here a little special bullet point that healthcare providers also have a high prevalence of obesity. And so we need to discuss that too. I actually talk a lot about this in my burnout and compassion fatigue videos, but healthcare workers have a high prevalence of obesity just due to the nature of our work, the stress of our work, the shifts of the shift work, and availability of foods and all of that. So when we're talking about obesity, we can't just talk about patients. We need to talk about healthcare providers ourselves as well. So the pathophysiology of obesity, basically, it is if you eat more than you expend, if you eat more than your energy you put out, then you develop larger and more adipose cells. When we eat, more than 70% of the nutrients and energy that we expend in a day is simply to keep us alive. It's that BMR, the basic metabolic rate, right? Just breathing, moving, digestion, metabolism in general, 70% of what we eat just does that. We only get about, do I have that on this slide? We only then need an extra 5 to 10% if we're active and exercising. So if we're eating in excess, it gets stored. It gets stored as fat cells, which is important for us because sometimes we need it. And especially, before the convenience of grocery stores and restaurants on every corner, if you stored your excess nutrition as fat, then when there was periods of famine where there wasn't food and resources, your body would be able to sustain itself. But we don't really have that problem here in America, do we? Hormones from adipose tissue in the GI tract and the endocrine system that signals with our hypothalamus when we're hungry and when we are full. So dysregulation of any of these can lead to obesity. Excess calories are stored as fat, like I just said. And then there's other things that contribute to obesity that are outside of the body, which is just the sight and smell of food. It can go either way, right? It can make people really hungry or make people not want to be eating. Memories of food to a social context. I have heard of people who associate eating with family and friends and having, good meals and desserts as this very warm and comforting feeling, or even like a reward type of feeling. And so that can lead to obesity if you're associating food with feeling good, but you're eating more than you actually need to eat. So there's a lot of mental aspects that go into weight loss or weight gain. Leptin is secreted from your fat cells, and this is actually an appetite suppressant. And so some studies or theories have thought that patients who are dealing with obesity might have a decrease in this leptin hormone. So when we think of appetite, that's when we're feeling hungry or when we're like, I need to eat, right? So appetite is regulated by our central nervous system. And a lot of times our appetite is triggered by a drop in our blood sugar. And our blood sugar makes us feel hungry. And so then we know it's time to eat. And then when our blood sugar rises, I know this slide says nutrition rise, a state of like a rise in nutrition, but really it's when your blood glucose starts to rise that you get the sensation that you are full. And I'm sure all of you have experienced this. If you are so hungry and you wait to eat your lunch and you just scarf down a big, burger and fries or whatever it is you're eating, it takes a while for you to feel that sense of, oh, I'm full now. So training people to give their body time once they eat something is, one of the interventions that we can do. And we'll talk about that further on in the presentation. So heredity may account for 40 to 70% of risk. This could be genetic factors, but it can also be lifestyle factors. Ethnicity plays a role in obesity risk. It says in our textbook that American Indian and Alaskan Native American adolescents are 30% more likely than non-Hispanic white people to be obese. Other factors that are risk factors are an infant with a low birth weight, children with parental obesity, sedentary behavior. So sedentary behavior is, not having a whole lot of activity, kind of like couch potato, is associated with sedentary behavior. Limited access or fruits to fruits and vegetables, limited access to healthy food in general. A lot of times healthier foods cost a lot more than fast food. Women who live in food insecure households, and genetics. So if we eat more calories than we expend, that's another risk factor. Lack of physical activity, lack of sleep. Interestingly, you need your full 7 hours of sleep a night. Otherwise, you are at risk for developing obesity. Genetics, use of certain medications. There's certain psych medications, medications to treat depression, seizures, and steroids that can cause weight gain. Easy access to fast food, lack of safe places for physical activity, modern culture and conveniences, oversized food portions, and our busy work schedule. So we don't have time to sit down and cook healthy food. We're just eating on the run, and limited access to healthy food. So how do we prevent obesity? Well, honestly, you need to start at birth because we need to have healthy habits from the beginning. And the parent's role is to provide good nutrition in the home, engage in family style eating. Now, I would actually like to take some time to research this because I haven't heard this as like a research based. If you eat as a family, then you have a lower risk of obesity. I don't know. I'm going to have to look into that one. Limit the time on the TV or video games, other sedentary behaviors. Patient education in all settings needs to occur. Partnership with public health organizations, healthcare providers in hospitals. So this I put here special so that I would remember. In some of the hospitals where I have worked in the cafeteria, the healthy items were the cheap items. If you wanted to have a burger and fries, it costs double what a normal burger and fries would cost. Now, that put the nurses in an uproar, but that was the hospital's way of keeping their employees on a healthier track. So I thought that was interesting. I do remember actually at one of the hospitals that I worked at, they took the fryer out so you could get like air fries, but you couldn't get fried fries. And the nurses threw such an uproar. I think they got a petition and the fryer was actually brought back. And then there's apps that you can use on your phone. I feel like I've talked about this in the other video, but that's okay. There's apps on your phone, like MyFitnessPal is the one that I have used, and it can track your water intake, your exercise level. I mean, you put it in yourself, but and all of the food that you eat so that you can have calorie goals and things like that. So the types of obesity, when I was putting this PowerPoint together and reading the chapter, I was laughing because, you know, you can definitely picture different people that you know that fit these different types of weight gain patterns. So there's upper body obesity. So that's more intra-abdominal fat. I think they have like terms for fashion reasons, like, are you apple shaped or pear shaped? And this upper body obesity would be that apple shaped body. But there's a big risk if you gain weight just in your midsection for complications like cardiovascular problems, metabolic syndrome, diabetes. And sometimes the people who gain all of their weight in the middle, but have those skinny, scrawny arms and legs, they can actually have a normal BMI, a normal weight, but they have central obesity. So they're still at risk for all of those obesity types of morbidities. And then we have lower body obesity. So this is more common in women. This is when the majority of weight gain is in the hips, thighs, and the buttocks. And so more common in women, but it has a lower risk of health problems than the central obese individuals. So this slide here is our body mass index. So on the one hand, in the book, it says that this is not the end all be all because, like I just said, the central obesity patients might have a low or normal BMI, but central obesity is still a lot of adipose tissue in the central area. So they're at risk for those problems. But there's also something in the book that says the body mass index is quite accurate in measuring health risks. So I don't know. I like to take the body mass index with a grain of salt because there's been many times in my life where my BMI is like, 25, but I don't feel like I look like I am overweight. So I don't know. Be careful with the body mass index. So complications of obesity. Well, there's the metabolic syndrome, which the bullet points here say increased waist circumference, that you also have hypertension, you'll have high cholesterol, you'll have high blood glucose, possibly diabetes, type 2 diabetes, and you're more at risk for atherosclerosis and coronary heart disease. And then obesity-related sleep apnea contributes to the risk of heart failure. So I think you guys will probably learn about sleep apnea further on in the program, but sleep apnea is so interesting because when you have sleep apnea, and if you have it due to the fact that you're obese or overweight, and you don't have anything like a BiPAP or a CPAP machine, is what happens is you never actually sleep, because the sleep cycle is supposed to be, over about a 7-hour period of time. And you go through different cycles in your sleep, and you go through REM and non-REM and rapid eye movement and all of that. But a good night's sleep regulates our metabolism, our appetite, so many different things. So if you are continually going hypoxic because you are not breathing properly because of sleep apnea, then you're waking up, every 5 minutes, every 10 minutes, and you're never actually going through the sleep cycle like you should be. So sleep apnea needs to be corrected. And actually, it's this vicious cycle, because if you have sleep apnea, you're not sleeping. And if you're not sleeping, you're at risk for gaining weight. And if you're gaining weight, you're at risk for sleep apnea. So, whoo. So if you or someone is at risk or has sleep apnea, they should definitely be seen by a sleep specialist and get that CPAP or BiPAP machine. So obesity, some other complications, the skin conditions with obesity. So here we have our Well, I'm going to let you read that one because I just can't really pronounce this. I'm going to let you read these because honestly, I can't pronounce all of them. And I don't want to sound silly on a recorded video, but I'll tell you what they mean. So here, where's my pen? Okay, so this one right here. Wait, yeah, I can't pronounce this, but this one here is actually dark, thick, velvety skin in body folds and creases. It typically affects the armpits, the groin, and the neck. And it's common in patients with obesity. Skin tags also a complication in obesity. These are those little bumps on your arms, stretch marks, cellulite, and this big foot callus. So those are all things that also are associated with obesity. So I got a little picture here. I think I have many more things. Yeah. Okay. So this is obesity risk factors. So if you have obesity, then you're at risk for all of these things. I'm going to read them off just so that we all hear them in case you're listening to this while you're driving or whatever. So myocardial infarction, also known as a heart attack, a stroke, hypertension, angina, so that's chest pain, atherosclerosis, obesity of the heart. So these are layman's terms, but that would be like cardiomegalia, diabetes, cholecystitis, which is gallbladder problems, pancreatitis, which is, inflammation of your pancreas, gastritis, inflammation of your stomach, violation of the endocrine function of the pancreas, violation, so also known as diabetes or type 2 diabetes there. Urolithiasis disease is kidney stones. Obesity of the liver, constipation, gout. So gout used to be known as the rich man's disease because it is caused by an accumulation of uric acid crystals in the joints because of eating excessive amounts of meat and alcohol, like liver, organ meats. So it's things high in purines. Osteoarthritis of the knees, all, joints, lower back pain, being flat-footed, sleep apnea, depression, different cancers, prostate, breast, and colon, stress incontinence, which just means that you urinate with any kind of like sneeze or cough or intra-abdominal pressure, and binge eating disorder. So a plethora of things can be prevented just by maintaining your health and your weight. So who are we going to work with to get our patients and ourselves healthy? Well, we are going to work with dietitians. Maybe pharmacology can be involved. Nowadays, there's all of those weight loss medications like Mounjaro and gosh, what are the other ones? Mounjaro, Ozempic. And so those are really hitting the market these days and helping a lot of people lose weight. We want to change eating habits, so physical therapists, and there can also be surgery. So we're going to talk about the different surgeries that you can have for weight loss as well. So diagnostic tests, well, you're going to do a height and weight, check their BMI, measure waist circumference, waist to hip ratio, weight to height, and then their neck circumference. So all of those measurements are in the textbook as to where they should be. And then, where it becomes risk for obesity. They're also going to have these labs done, thyroid, serum glucose, their cholesterol, lipid profile. They'll have an EKG, electrocardiogram, check their heart, see how that's working. And then underwater weighing, hydrodensitometry, is actually kind of the gold standard for how much of your body weight is fat. And then the bioelectrical impedance is some kind of test where they send like an electrical signal through your tissues to see how much fat is actually there. So those are some tests that they can do to check I guess all the aspects of your weight. So let's talk about exercise. Exercise is a critical part of losing weight and keeping it off. It increases our energy consumption, and so it also increases our BMI, right? Or our metabolism. It promotes weight loss, it preserves lean body mass, it improves our physical fitness, improves our cardiovascular system, decreases our appetite, and promotes self-esteem. I have some things to say about exercise, but evaluation by a healthcare provider is important for any patient before beginning an exercise program, because we definitely want them to remain safe, right? Because I'm glad that this is on this slide, because sometimes exercise can be hard, because if we have patients who are in a lot of pain, exercising can exacerbate that. So finding out what activity will be good for our patients is going to be important for their success in their exercise program. We have to be realistic. We're not going to tell someone who just had an MI that we want them to run 10 miles a day, right? We need to be realistic with what we're doing. So 30 to 40 minutes of exercise 5 days a week promotes our weight loss, reduces adipose tissue, so our fat cells, increases lean body mass, and promotes long-term weight control. So making this a lifestyle change is what we are going to want our patients to do. So sustaining weight loss requires the incorporation of new patterns. I just saw a quote the other day that was like, if you want to have a new life, you need to leave your old one behind. So same thing with these patients. It's like if they have been obese all their life because of their lifestyle and because of their diet, they're going to have to make huge changes that might actually be, hard for them to do. And I have a drink of my hot chocolate while I say that. So all of the treatment mentalities for this patient's plan of care needs to involve the alteration in food intake and dietary practices. So a good skilled dietitian will be able to work with a family to make changes to their dietary practices while maintaining compliance that they're still going to follow the diet plan. Okay, so that is kind of an important part of this. Increasing our macro intake, improving the consumption of fruits and vegetables, eliminating empty calories. So empty calories would be something like a soda or a Slurpee. You get absolutely no nutritional value from it. It doesn't make you feel less full, and yet it has hundreds of calories. Use the app to help you with diet control. Eat your meals together. Avoid eating while you're watching television. And to piggyback onto that, just avoid mindlessly snacking. Let me ask you this question. Have you ever had a bag of something that you really wanted to eat, let's say cookies or chips or something, and you go to get one and they're all gone and then you're sad? Or is that just me? But that's mindlessly eating. So is what you're supposed to do is, if you have your little treat of, cookies, stop what you're doing. And as you're eating the cookie, you mindfully eat it. Oh, this tastes so good. I like the way the chocolate tastes. It's crunchy. Be present while you're eating and enjoy it and savor it. And then you won't be mindlessly snacking. And always eat breakfast. So many times when I was assessing patients, if they were overweight or obese, and I would go through their dietary habits, half the time they said they didn't eat any breakfast. But eating breakfast is so important, even if you're not hungry. And all you have to do is have like a tiny piece of toast with some peanut butter on it. You're getting some carbs, you're getting some protein, and it will rev up your metabolism for the rest of the day and make it so that you aren't so starving when your next meal is due to come. So always eat breakfast. So we need to screen all of our patients for obesity, help them make long-term changes. We need to help them set specific goals. So SMART goals. If we haven't already gone over this in class, let's do it right now. A SMART goal is specific, measurable, attainable, realistic, and timed. So the slide says relevant, but realistic works just as well. And is what I mean by this is if you have someone who has never exercised a day in their life, maybe walking down the block once a day is a good goal to start with. And then when they check back in with you, then maybe we can make it twice a day. So these need to be smart goals. You're going to go to the gym once a week for 30 minutes on the treadmill and build from there. So they can keep food diaries, food activities, and self-record their weight. And they can go to support groups, Weight Watchers and Overeaters Anonymous. I actually have a coworker somewhere else where I work, and she and her daughter go to Overeaters Anonymous, and it's a whole community. And she's actually been maintaining her weight and doing really well. So prevention of obesity, again, this is another, I mean, this is a licensed picture that I'm allowed to use, but it is with layman's terms. But preventing obesity, avoid stress, get enough sleep, cut out fast food. I think if it's not on here, well, maybe getting rid of bad habits, cut out that mindless snacking. Just don't do it anymore. Things like eating chips while you're watching TV, just mindlessly eating chips out of the bag while you're watching TV, that's consuming so many calories and you're not even really present and aware that you're doing that. Do physical exercise, less TV, drink enough water, and eat more fruits and vegetables. And then here, get rid of bad habits. So let's talk about the surgery. So say you've done everything. Oh boy, we've exercised, we've limited our calories, we have done all the behavior modifications. Nothing seems to be working. Then we can move on to discussing surgery with our patients. And there's a few different types of surgeries. And I have actually personally known many people who have had the gastric bypass or the gastric sleeve or the gastric banding. And so I actually have personal experience talking about this because all of them had sort of different experiences. And then actually the last hospital that I worked at, the floor that I did my rounds on was the bariatric surgery floor. And so I would talk to all of the patients after they had the surgery. And so a lot of times these patients were really excited for sort of this new chapter in their life. So there's restrictive procedures. So they make the stomach smaller. They reduce the capacity of the stomach. So there's adjustable gastric banding. This isn't used as much, but is what it is it's a gastric band and it has a subcutaneous port. So you can fill it up with a solution via the skin to make it bigger or smaller. So I actually had a neighbor who had the lap band. And I remember her telling me like, oh, it's my birthday weekend. So I'm going to the doctor to like release my gastric band so I can like, you know, really eat and stuff. So I was surprised that you were able to do that. There's also the vertical banding where they put the band on, but they also make a vertical incision in the stomach and kind of make the stomach smaller. And then what else do we have on here? So that makes a small pouch in the stomach. And these aren't performed very frequently. They have limited success. There's a lot of complications with these surgeries. And it's better for like the actual bariatric surgery, like the gastric bypass. So we'll talk about that one. So the gastric bypass is where they just bypass the stomach almost altogether. And so, yeah, in the gastric bypass, they make a small, tiny pouch, and then they bypass the stomach altogether and connect the duodenum up at that small pouch that they just made. So these surgeries have rapid weight loss and it is maintained over time. About 60 to 70% of the patients report maintained weight loss at a 10-year mark. The complications with this type of surgery, the gastric bypass, is this isn't in our book, but the people that I have known, they were eating for a reason. And so when they got their gastric bypass and ended up losing all that weight, they still had problems with dealing with their emotional reasons why they were eating. So I saw that quite a few times. In fact, I looked up quite a few articles on it, on like how someone who has had gastric bypass can oftentimes be at risk for the developing like a drug or alcohol problem afterwards, because they were dealing with their emotional conflict and emotional pain by eating, and now they can't do that anymore, so they turn to something else. Just FYI, it's not in the book, but I find it an interesting fact. And then because they don't have a stomach anymore, they have deficiencies in vitamins because they can't absorb the vitamins, so they have to take supplements for that. I think it's mostly like iron and B vitamins. So there's high risk post-operative complications for some of these. The staples can leak, and you know that's gastric contents leaking into your abdominal cavity, so that can be causing infection and peritonitis. There's nausea and vomiting, severe reflux, and dumping syndrome. Dumping syndrome is when if you eat a high carb or refined sugar type of meal, it causes severe bloating, diarrhea, because the carbs just make an influx of fluid coming into the intestines and stomach. There can be slippage of the band. There can also be ulcers. So, but the outcomes for the surgery can be positive. There's major weight loss. It will improve their blood sugar. It improves their blood pressure. It improves their quality of life and their sexual life and their self-esteem in general. And the women that I know that had this surgery, I know 3 personally. One had the lap band. I don't think that she lost all that much weight, but the 2 that had the gastric bypass both lost 100 pounds. So lifespan considerations, we have obesity in children and adolescents. So this is when their BMI is in the 85 or 90th percentile of children of the same age and sex. And children with obesity suffer from the same health disparities as adults: high blood pressure, type 2 diabetes, depression, cancers. They're more at risk for fractures and skin problems, malignancy. Childhood obesity is becoming more prevalent because of, you know, the increase in screen time, video games, watching TV. If they don't have a safe environment where they can go outside and play, that's contributing to our obesity rates. Poor food choices, snacking on chips and having soda instead of having, you know, healthy snacks. And a lot of times the children don't have control over this. Obesity in pregnant women. So this is a common high risk complication, but it increases the risk for miscarriage, preterm birth, cesarean deliveries, and obese mothers are at risk for metabolic syndrome and gestational diabetes. And when a mother is obese during pregnancy, that also gives complications to the fetus. So the fetus is at risk for macrosomia, which is large for birth age, cardiac malformations, intrauterine demise, so stillborn, chronic kidney disease, born with ADD, attention deficit disorder, autism, and spectrum disorders. Breastfeeding does help with weight loss, and it helps with the baby to maintain their weight. So breastfeeding for 6 months to a year is ideal. If the woman is obese before getting pregnant, it is ideal for the woman to go on a weight loss journey beforehand so that she starts her pregnancy at an ideal weight. And it is safe for pregnant women to lose weight. So maintaining a healthy weight begins in utero. So even before birth, I said it started at birth in the beginning of this video, or the video. But promote healthy eating, and nurses are really prone to obesity. Follow the same advice about healthy diet, exercise, and weight control. You've got to be careful, guys, when you go into nursing because of our shift work, the stressful hours, working night shift, you know, inhibits our sleep patterns. And people love to bring nurses donuts and treats and candies. So be sure to be careful once you get into this field. So our assessment for our patients, observation, and our patient interview, we want to know like their general appearance, posture, and gait, their current weight, their usual weight, have they recently gained weight or lost weight, their diet, their food intake, their dietary preferences, review of their exercise patterns and activity levels. Do they have comorbidities, which means do they also have high blood pressure? Do they also have diabetes? Do they have heart problems? That's comorbidities. And then what medications are they taking? And the patient's perception of their body weight. Do they see a problem with their weight? Are they feeling fine and happy with their weight? That's important to know. We're going to take their vital signs, their height and weight and daily weights. We're going to do their hip to weight ratio and check their skin integrity because obesity causes all those skin problems we just talked about. And then our nursing diagnosis, my favorite, risk for obesity or obesity in general. Depending on your patient's presentation, do they have low self-esteem? Are they knowledge deficit? Do they not know about healthy eating? Are they activity intolerant? Are they lacking in health maintenance skills? We could also look at their resources and see if they need more support in order to make these healthy changes. So planning, we're going to plan our exercise routine with them. We can even just start with walking up and down the hall with them, making a list of goals that they want to achieve, getting them in touch with dietary, giving them resources for support groups, and demonstrating appropriate weight loss. I think that might be it, you guys. Okay, so then we have done nutrition, hydration, obesity, and that's it. Thank you for watching.